While the world watched in horror the COVID-19 decimating large cities in India, the virus stealthily began to devastate rural India. While oxygen shortages caused suffering to healthcare workers and patients in larger cities, the rural folks could not even make it out of their villages. And rural areas in India have been plagued with very poor infrastructure. Rural folk would often die on their way to the larger hospitals and towns. And even when they managed to get there, they would often be sent back with no hospital beds available. When patients were able to get beds, they often found it hard to pay for the care received in private hospitals due to the exorbitant costs and out of pocket paying model that's vastly prevalent in India. To solve the problem, a group of concerned citizens led by J.K. Ayana, Brigadier Devaiah, Rajiv joined hands with Karuna Trust, an international NGO taking care of primary healthcare needs in India, Scanray Technologies, Mr. Alwa, and Dr. Amrit Nanaiah from Lopamudra Medical Center, a hospital in Kodagu, to set up a dedicated COVID high dependency unit. Organizations like Kodava Kuta and Dina Bandhu, along with many philanthropists, helped raise funds to set up the hospital and provide care for patients. This was set up in a rural village in Karnataka, India, in the Western Ghats. The group decided to treat patients for free. Philanthropists even provided food to take care of patients in the hospitals. Once decided, the hospital was set up in about a week. This on the face of a pandemic and a national lockdown. Funds were mobilized, oxygen supply chains established, beds and health infrastructure procured, doctors and nurses hired. With the help of infectious disease physicians at the University of Florida, led by Professor Southwick, a protocol was developed for settings with limited resources. A telemedicine facility was developed so that physicians at the center could discuss complicated cases with ID physicians in the US daily. The protocols were revised based on feedback from physicians at the COVID care center. Admission, transfer, and discharge protocols were developed, considering that the closest tertiary hospital was about an hour and a half away. Labs were restricted to total count, CRP, absolute lymphocyte count, creatinine, liver function tests, D-dimer. More labs were only ordered if necessary and depending on the patient's condition. Treatment involved either remdesivir, dexamethasone, and in a few patients, interleukin-6 inhibitors like tocilizumab. No antibiotics were used. Before the center became operational, ID physicians from the US trained healthcare workers on infection control practices, pathophysiology, clinical features, diagnosis, and management of COVID-19 disease. This was indeed a multinational, multidisciplinary collaboration to fight the COVID-19 pandemic and show that with commitment and dedicated members in a team, no region has to suffer the despairs of the pandemic. So now we're going to show you a few examples of telemedicine collaborations across the world. I want to introduce you to Dr. Amrit Nanaiah, MD, the physician taking care of patients at the COVID Care Center in Attur village in Kodagu, in Karnataka, South India. I also want to introduce you to Kalpa, one of the physicians taking care of the patients in the COVID Care Center, who will present cases today.
Okay. So the first patient who I'll be presenting is in the range of 70 to 80 years old, a lady who is today on her 12th day of illness. She's a known case of diabetes, hypertension, asthma, and ischemic heart disease. She has a NEWS2 score of 6 today, which is increased since yesterday. And she has a CT score of 9 on 25. Her saturation is 94% on 1 liter of oxygen, and in room air it's 88%. She has no fresh complaints today. We had started her on remdesivir. We had given her 3 doses of remdesivir, and then we held back since her serum creat was on the higher side. And today she's on her 6th dose of steroids, dexamethasone, and she's also on heparin. Her labs are, as of today, her creat is better. It's 1.5, and yesterday it was 1.68, which is why we have decided if we could give her 4th dose of remdesivir tomorrow after a 72-hour gap. Whereas her CRP is 31, her ALC is 1200, and her D-dimer was 6,094.
So how do you think she's doing? What's your impression?
So her creat values have come down. So I think we could go ahead with the fourth dose since we held it for the past 72 hours.
And overall, how do you think your COVID-19 or SARS-CoV-2 infection is responding? What do you think?
I think it responds well to remdesivir when it's given within 1 week of the illness.
Yeah, her lymphocyte count now is up to 1,200.
It's improved.
So that's
Yes,
a
it's
very
improved.
good sign. And her CRP is going down, which indicates dexamethasone is working. So all parameters are D-dimer is stable. I would say it's the same, but it is not going up significantly. So I think she has severe disease that is slowly improving, and there is evidence for response to remdesivir. So what do you want? Do you want to change anything?
I think we could go ahead with the fourth dose of remdesivir tomorrow.
Right. So we'll continue the dexamethasone, give the fourth dose of remdesivir. And I'm very encouraged. I think she's going to do well. Great. Next case.
So the next case I'll be presenting is a lady who is in the age group of 60 to 70 years. She's a known hypertensive on medications. Today is her 10th day of illness, and her NEWS2 score is 6. It was 4 on admission, and now it has progressed to 6. Her saturation today is 94% with 1 liter of oxygen, and on room air it is 88%. Her respiratory rate has reduced to 38. It was 44 yesterday. She has finished her entire course of injection remdesivir, all 5 doses. And today she is on her 6th day of steroids, dexamethasone. She's also on heparin. And her labs, her CRP has reduced from 99 to 5.8. Her absolute lymphocyte count has increased from 800 to 1,000. And her D-dimer has increased a little from 93 to 463. Her CT score was 15 on 25 at admission, but her saturation seems to be, her oxygen demand seems to be worsening because at admission her saturation was way better.
Yeah, so she seems a little bit worse. Gautam, what do you think?
Yeah, I think she's definitely a lot worse than she was yesterday.
Yes.
And how is she clinically, Kalpa?
She seems fatigued and very easily fatigued, especially if she has to move out of her bed. She seems very fatigued.
Do you think we should consider her CRP is relatively low, so I don't know that she would benefit from tocilizumab. What do you think, Adam?
Yeah, exactly. Though, she came with a CRP of 99, which went down to 34, just gone up a little bit, but she does not still meet the criteria for tocilizumab. So I guess we will continue to watch her and, kind of closely monitor her clinically to see, to kind of make sure that she's not going into any respiratory failure as such.
The next patient is a lady who is within the age range of 60 to 70. She is a known hypertensive and diabetic. She is today is her 10th day of illness. Her NEWS2 score was 6 on admission. It had increased to 8, and now it has reduced to 7 today. She was on 30 liter of O2 and high flow nasal, but today we have reduced it to 20 liter, and her saturation is maintained at 95%. Her respiratory rate has also come down to 32 per minute. Her CT score was 18 on 25 at admission, and we gave her 2 doses of remdesivir that was given, and we had held it back because her creat was on the higher side. And today we will be giving the third. Her creat was 1.2 and earlier. Now it's come down to 1.3. Her D-dimer was 1085, but now it's 1495. Her CRP was 143, and now it is 72. And her absolute lymphocyte count was 1000, and today it is 1500. We have also given her, we had given her tocilizumab when she was worsening, but now her CRP is reducing and she's showing an improvement.
Gautam, any thoughts? Anything else we need to do with her? What do you think?
No, Amrit, any thoughts from your side?
She's doing fine, Dr. Gautam, but no, the oxygen requirement, we thought we will just be reducing the FiO2. And like discussed yesterday, we thought we'll keep the flow rate slightly on the higher side to give that extra peak, and we'll start reducing the FiO2 and see how she does.
Good. Yeah, I think she's improving. She's definitely improving. Her lymphocyte count is up. Her CRP is down. So I think we're making some headway. It's slow. It's a slow recovery, but we're moving in the right direction.
Right, and she is, and Dr. Amrit, she is a diabetic, is she? I forget.
Yes, she is a non-diabetic.
Yeah.
Sugars are well under control.
Yeah.
She's diabetic. She's getting metformin and insulin because when the creatinine had gone up, we were thinking of reducing metformin or stopping metformin. But now that she's stable, we are continuing her with insulin.
Very good.
Good evening, Dr. Southwick and Dr. Gautam. I'll be briefing up the summary about the work, what we have been doing since the past 1 month. We started our COVID ward on the 15th of May last month, and we have ever since then we have admitted up to 67 patients. Of the 67 patients, our average in-hospital duration of each of the patients were 4.5 days. 30 of our patients, of the 67 patients, have received remdesivir. 45 of them we have given dexamethasone. 43 of them required oxygen, and tocilizumab was given to 2 of our patients. 10 of them required antibiotics, and the antibiotics was used for urinary tract infections and 1 patient who had osteomyelitis. There was a documented evidence of infection, and antibiotics was not used for COVID-19 pneumonia per se. We lost 1 of our patients, an 88-year-old lady for COVID who was rapidly progressing. Another patient, we had to shift her to an ICU because her oxygen requirement was going high and she was deteriorating. But for these 2 patients, all our other patients have gone home after being cured of COVID. Thank you.